Hello everyone, and welcome to my YouTube channel, Studyholic Doctor. My name is Jeongshik Son. I recently had the privilege of speaking at the World Organization of Family Doctors Asia Pacific Region Conference 2025 in Busan. Today, I want to share the core messages from my presentation with you, discussing the latest updates on hypertension management for primary care physicians, drawing from major guidelines and clinical trials. In the world of hypertension guidelines, we primarily look at two key sets: the 2017 American College of Cardiology American Heart Association guidelines and the more recent 2023 European Society of Hypertension guidelines. There's a notable difference in their diagnostic thresholds. The ACC-AHA guidelines define hypertension as blood pressure higher than 130, while the ESH guidelines use the threshold of higher than 140. May I kindly ask for a quick show of hands? Who follows the American guideline? Who prefers the European guideline? Despite these different diagnostic thresholds, both guidelines emphasize three crucial aspects of hypertension management. First, accurate blood pressure measurement is paramount. Second, home blood pressure monitoring is strongly recommended for both diagnosis and follow-up. And third, the early use of combination therapy is encouraged for better blood pressure control. Let's start by dividing into why accurate blood pressure measurement is so crucial. Accurate BP measurement is actually not easy. Blood pressure measurement errors can be quite large. Here are some common measurement pitfalls and their potential impact on SBP. Using an inappropriate cup size is a major issue. A cup that is too small can add 5 to 20 mHg to the SBP reading, while a cup that is too large might forcibly lower it by 1 to 6 mHg. Proper cup size must match arm circumference. Not resting for 5 minutes before measurements can increase SBP by 10 to 20 mHg. Talking or texting quietly during measurement can add 10 to 15 mHg. Avoiding caffeine for 30 minutes before measurements is important, as drinking coffee can increase SBP by 5 to 8 mHg. Having a full bladder can increase SBP by 10 to 15 mHg. Alcohol consumption before measurements can add to 5 to 8 mHg. Sitting without back support, like upright on examination table, can increase SBP by 5 to 15 mHg. Crossing legs or having legs dangling from the examination table can add to 5 to 8 mHg. Measuring people overcrowding instead of on a bare arm can cause a significant variation from 10 to 15 mHg. Proper cup size and arm position are essential for accuracy. As mentioned, cup size must match arm circumference. An undersized cup leads to falsely high BP readings. For those who need a large cup, An undersized one measured SBP 4.8 mHg higher than in a study. For those needing an extra large cup, it measured SBP 19.5 mHg higher. Conversely, an oversized cup resulted in falsely low BP readings, measuring SBP 3.6 mHg lower for those needing a small cup. The arm should always be supported at heart level. An improper position may alter BP by 10 mHg or more. Let's quickly review the different methods of BP measurement. We have office BP, which can be routine office BP or research office BP. Then there's ambulatory blood pressure or ABP, and home blood pressure or HBP. Finally, automated office BP or AOBP. AOBP can be attended with a healthcare professional present or unattended with the patient alone. The SPRINT trial was a landmark NIH-funded hypertension randomized controlled trial. It enrolled over 9,300 patients at high cardiovascular disease risk, excluding diabetics. The trial compared an intense BP target of less than 120 mHg versus a standard target of less than 140. The intense treatment group showed reduced cardiovascular events and mortality. This trial significantly supported the ACC-AHA target of less than 130 mHg and influenced the 2017 American Guideline definition of stage 1 hypertension. Crucially, the BP measurement in the SPRINT trial was unattended AOBP, meaning the patient was alone. The protocol involved the patient being seated in a quiet, empty room, rested for 5 minutes in a chair with back support, and no talking or step present during measurement. BP was measured automatically 3 times at 1-minute intervals. The SPRINT trial found that if AOBP was higher than 130, AOBP readings were 14.5 mHg lower than routine office BP. AOBP was found to be similar to daytime ambulatory BP mean. This led an understanding of the hierarchy of BP readings across methods. Routine office BP is typically higher than research office BP, which is typically higher than awake ambulatory BP, and unattended AOBP, which are roughly equivalent. Attended AOBP is also approximately equivalent to unattended AOBP. Looking at the mean BP results, unattended AOBP was 129. Attended AOBP was 129, and the daytime average AUBPM was 128. This data reinforced that AOBP, both attended and unattended, is closer to ambulatory BP than routine office BP. Summarizing The difference is according to measurement method. I see the trend. Routine office BP is highest, followed by research office BP. Awake ambulatory BP is generally equivalent to attended AO BP and unattended AO BP. Home BP is also an important method. It is crucial to apply the sprint finding to the real-world practice carefully. Sprint trials results should be based on BP measured with AO BP and should be applied to the same patient population as the study. Specifically, those with hypertension who are without diabetes and are relatively healthy but have many cardiovascular risk factors may consider more intense BP control, but only after accurately measuring BP by AO-BP. Let's briefly look at the STEP study from China. Subjects were elderly, aged 60 to 80 years old, with an average age of 66. They were relatively healthy with a low history of CVD, 6%. Their average baseline BP was 146. The target BP comparison was less than 150 versus less than 130. Exclusion criteria include DBP less than 60, stroke patients, and those with cognitive impairment. Over 1 year, the average BP in the standard treatment group was 135, while in the intensive treatment group, it was 127. The BP measurement protocol in the STEP study was also rigorous. Patients seated for more than 5 minutes in a seated position. A healthcare professional used the automated device to measure BP 3 times at 1-minute intervals. Recently published BP road trial showed that intensive BP control benefits in patients with type 2 diabetes. The BP road trial also followed a standard protocol recommended by the American Heart Association. Participants were advised to avoid alcohol, cigarettes, coffee, and exercise for at least 30 minutes before measurement. They were seated comfortably with back supported, upper arm bared, legs not crossed, and arms supported at the heart level. An auto BP cuff was also used as the appropriate size. Pediatric size, regular adult size, or large size were chosen based on the arm circumference. BP was measured 3 times after 5 minutes of seated rest with 1-minute intervals in the presence of an observer. Neither the participant nor the observer should talk during the rest period or measurement. An automated device was used to reduce observer biases and step effort. The mean of the 3 measurements were used. Comparing the BP measurement practice in these clinical trials, sprint, step, BP road, versus typical office practice, highlights the key differences. Measurement method. Trials used the automated validated oscillometric devices, while offices use the often used manual or semi-automated method. Environment. Trial use a quiet, empty room. Offices are typically busy, with steps present. Rest period. Trial mandated over 5 minutes of seated rest. Offices often have under 1 minute or none rest. Number of measurements. Trials took 3 measurements at 1 minute intervals. Offices usually take 1 or 2 measurements. Arm position. Trial ensured the arm was supported at heart level. Offices often leave it unsupported or below the heart level. Cup size. Trials use appropriately sized cup based on arm circumference. Offices often use a standard cup, not adjusted for size. BP value used. Trial used the average of multiple readings. Offices typically use a single reading. The clinical implication of these differences is significant. The rigorous methods in trials yield lower and more accurate BP readings, which supported intensive treatment goals. Typical office practice. Risk overestimated BP, leading to potential over-treatment. Therefore, standardized accurate BP measurement is key to applying the evidence from randomized clinical trials like SPRINT, STEP, and BP load. These trials used rigorous BP measurement protocols, and applying their results in clinical practice requires using the same methods. Without standardized measurement, BP may be overestimated, which can lead to over-treatment and increase the risk of adverse events, such as orthostatic hypotension, falls, and fractures, acute kidney injury, and myocardial ischemia. Guideline recommended techniques ensure safe translation of trial evidence. This brings us to why home BP monitoring or HBPM matters. In real-world practice, standardized BP measurement, like in trials, is not always feasible. Home BP monitoring provides a reliable alternative to the AOBP used in trials. It captures day-to-day BP variability in natural settings and reduces the risk of white coat hypotension and masked hypotension. This enables the safer application of RCT-based targets like those from SPRINT and STEP trials. Both ACC, AHA, and ESH guidelines recommended home BP monitoring for diagnosis and follow. Home BP monitoring is essential for both diagnosis and management. It captures real-life BP variability, helps detect white coat and masked hypotension, and improve treatment decision and patient adherence. Home BP monitoring is essential. A study of over 59,000 patients in Spain found that office SBP has a weak association with death and cardiovascular death compared to ambulatory BP. The risk of cardiovascular disease increased more with the increase in home BP and ambulatory BP than with office BP. Masked hypertension, diagnosed by home BP measurement, is associated with increased stroke risk. Home SBP has also been shown to be more reliable and have a stronger correlation with left ventricular masses than office BP or ambulatory BP. Here's the recommended protocol for performing home BP monitoring. Use a validated cupped upper arm device. Measure BP twice daily in the morning and the evening. At each session, take 2 consecutive readings 1 minute apart. Sit quietly for 5 minutes before each session. Avoid caffeine, exercise, or smoking for 30 minutes beforehand. Record readings for at least 3 to 7 consecutive days. Discard the value from the first day, as they may be higher due to tension, and use the average of the remaining readings for analysis. Ensure the arm is supported at heart level and the feet are flat on the floor. Moving on to the third common emphasis of the guidelines, early use of combination therapy. Early use of combination therapy improves BP control, enables faster achievement of target BP, reduce therapeutic inertia, and enhance adherence. Single pill combinations are preferred to simplify treatment. Both the 2017 American Heart Association and the 2023 European Society of Hypertension guideline recommended combination therapy. The 2017 AHA guideline recommended it for stage 2 hypertension, higher than 140. The 2023 ESH guidelines go further, recommending single pill combination for most hypertensive patients. Exceptions might include a low-risk stage 1 hypertension with BP lower than 150, elderly patients over 80 years old, frail patients, or very high-risk patients with high normal BP. Common components for combination therapy are often summarized as ACDS. A stands for ACE inhibitor or ARB. C stands for calcium channel blocker. D stands for thiazide or thiazide-like diuretics. S can stand for statin for ASCVD risk reduction, which is widely recommended in high-risk hypertensive patients. S can also stand for spironolactone for resistant hypertension, meaning uncontrolled BP despite over 3 combination drugs. Single pill combinations are preferred when feasible. The Quartet trial was a phase 3 multicenter double-blind RCT that investigated an ultra-low-dose quadruple therapy. It compared a quadruple against monotherapy. The quadruple contained irbesartan, amlodipine, indapamide, and bisoprolol compared to monotherapy control with irbesartan normal dose. The trial enrolled 591 adults with hypertension who were not on treatment or on monotherapy. The primary endpoint was the average in unattended office BP at 12 weeks. The results showed that the quadrupil group achieved 6.9 mHg lower SBP at 12 weeks compared to monotherapy, and this greater BP control was sustained at 12 months. The quadrupil was also well tolerated with a low incidence of adverse events. Let's look at a case study to see how these principles apply. My case is a 38-year-old male, height 172 cm, weight 89 kg, giving him a BMI of 30. His waist circumference was 96 cm. He usually snored heavily and often had a sleep apnea, which worried his wife greatly. His office BP was 136. An abdominal ultrasonography showed fatty liver, and the urine test showed albuminuria. Professor Sang-min Park and I conducted a Korean big data study and found that among young adults in their 20s and 30s, a blood pressure higher than 130 was associated with an increased risk of cardiovascular disease. This study was published in JAMA. A younger age at hypertension onset has been associated with higher risk of cardiovascular disease and all-cause mortality, as demonstrated in a Chinese observational study. Back to our case, the patient present with albuminuria and his office BP was 136. Given this, there's a high suspicion for masked hypertension. His office BP may underestimate his true BP load. Therefore, home BP monitoring was recommended. Home BP monitoring detects elevated BP outside clinical settings, improves diagnostic accuracy, and helps guide appropriate initiation or intensification of therapy. I asked the patient to measure his home BP and the pulse rate over 9 days using the recommended protocol. As a protocol, I discarded the first day's measurement due to potential tension and bias. Let's look at the data from day 2 to day 9. Morning readings averaged SBP 137, DBP 81, and the pulse rate 79. Using the 8-day morning BP mean, the patient's average was 137. Let's compare this to the standard definition for different BP measurement categories. Home BP mean higher than 135 indicates hypertension. My patient's office BP was 136, which falls into the hypertensive range by ACC-AHA criteria, but not by ESH office BP criteria. However, his average home BP morning readings was 137. Therefore, the patients met the diagnostic criteria for hypertension according to both ACC-AHA and the ESH guidelines. Analyzing the home BP and pulse rate data, The morning SBP mean was 137. This meets the criteria for morning hypertension. The standard deviation of morning SBP was over 24, indicating high BP variability. The morning pulse rate mean was 79, which is a high mean pulse rate. The standard deviation of morning pulse rate was higher than 7, showing high pulse rate variability. These findings, morning hypertension, high BP variability, high mean pulse rate, and high pulse rate variability, are all associated with higher cardiovascular risk. According to both American and European hypertension guidelines, based on his office BP and his home BP measurement, the patient met the criteria for hypertension. To prevent hypertension-mediated organ damage in this patient, hypertensive therapy was initiated. I started with a single pill combination of ARB and CCB at half dose. Furthermore, I emphasized weight control through diet and exercise, as sleep apnea measurement is also important for hypertension treatment in this patient. Let me summarize the key takeaways in hypertension management from my presentation. First, accurate BP measurement is the foundation of diagnosis and treatment. Second, home BP monitoring is essential for detecting masked hypertension and guiding long-term management, as it provides a more accurate picture of real-life BP. Third, early use combination therapy improve BP control and reduce cardiovascular risk, with single pill combinations often preferred. Thank you for watching. I hope this summary of the latest updates in hypertension management for primary care physician is helpful in your practice. Thank you.